Year-old male is a known case of coronary artery disease, systemic hypertension, on regular medication. Now come to ER with difficulty in breathing since last 1 hour. She was taken to ER bed. Now you have not started anything. You can manage the case.
As patient has come with severe breathing difficulty, we will be triaging the patient and we will be taking the patient to the red area, and we will ask to connect to the monitor, cardiac monitor will be connected.
We are connecting. Meanwhile, 10-second assessment can be started.
Okay, on 10-second assessment, we will be checking whether the patient is conscious oriented.
Is conscious oriented.
And we'll be also assessing the way, whether the patient is able to speak in full sentence
Not
or
able to speak in full sentence. He is in distress.
Okay, so now we'll be going ahead with the airway. So
Airway, lot of secretions are there, and there is no foreign body. We have examined the case, and trachea is normal.
Okay, so in airway part, since there is no there are secretions, we'll have to suction the patient.
Start, sir.
Please suctioning the patient. And since there is no any foreign body or gurgling,
No foreign body.
no gurgling, so then airway is patent, so we can go ahead with the breathing part.
Okay.
Coming to the
Can auscultate.
yeah.
Bilateral chest movements are equal, but accessory muscles are in use because of respiratory distress. Coarse crepitations are there on both sides. Respiratory rate is 40. SpO2 is 88%. In room air, we have not started anything now.
Okay, since in the breathing part saturation is only 88%, we'll have to connect the patient to the oxygen. So we'll be supplementing the patient with O2 via the facial mask. And since on auscultation I have got bilateral crepitations, we'll be also arranging meanwhile the non-invasive ventilation.
Yes, connect to the mask. Oxygen, how much oxygen to be given?
Oxygen, since it is 88%, we can initially connect with a 5 liter or O2 and see whether saturation is picking up, and we can maintain a saturation above 90.
Okay.
And meanwhile,
NIV is ready now.
so as NIV is ready and patient is having bilateral crepitations, we will be connecting the patient to the non-invasive ventilation.
So
And
we are connecting to NIV because it's not improved with your routine oxygen mask. We are connecting to NIV. Settings.
Settings we can keep with pressures of 12:6 since we are suspecting pulmonary edema. Since the patient is the known case of a CAD, we are suspecting it to be a pulmonary edema. So we will be setting with the pressures of 12:6. And meanwhile we will be ordering for a chest X-ray.
Okay.
So we will be getting a chest X-ray done.
Okay.
And then we will be coming to the circulatory part.
Okay. You can see the pulse. It is connected to the monitor. You can see that heart rate is around 180 beats per minute, and it is totally irregular. Okay. BP is on record. It is 79, 80 by 40.
Okay. So in circulatory part, first of all, we'll be asking to secure 2 large IV bore cannulas.
Please put IV cannulas.
And then as the monitor shows, we can see patient is in tachyarrhythmia, and the rhythm it is showing an irregular narrow complex QRS complex. So we'll ask to get a 12 lead ECG.
Okay.
So
we have taken in 12 lead ECG already. It shows atrial fibrillation with fast ventricular rate of 140. BP is low.
BP is low. So the monitor is showing a BP of 79/41, and patient is in severe distress. Patient saturation is low. Patient's BP is also also in hypotension. So since the ECG is showing irregular narrow QRS complex with no morphological P waves, we should see the patient as to be in unstable AF, and in unstable AF we'll have to go ahead with the synchronized cardioversion. So we'll be getting ready with the defibrillator. We'll be connecting the patient to the defibrillator.
You can tell the technician to connect and charge the defibrillator, and you can give the shock.
So initially we'll be connecting the defibrillator to the patient, and then since it is unstable AF, we'll have to give synchronized cardioversion.
Okay.
So we'll have to press the sync button there,
Okay.
and then we'll be charging the defibrillator to 120 joules.
120 joules.
120 joules. Initially 120 joules can be given, and then after
Synchronized cardioversion.
And then we'll have to charge the paddles, and we'll be placing the paddles in anterior lateral. That is, anterior paddle will be kept just below the clavicle, right to the
Fully
sternum.
conscious, oriented.
Yes.
You want to give anything
Yes.
else?
Before giving a cardioversion, we'll have to get the consent of the patient, and since the patient is
Patient
fully
bystanders given consent for DC cardioversion.
Since the patient is fully conscious, we'll have to explain the patient the procedure, the cardioversion procedure, and also since it is a painful procedure, we'll have to give the patient sedation.
What do you want to
Usually, you can give any combination. You can give Midas plus morphine or
give? Give a Midas plus morphine.
Midas and morphine has been given.
and meanwhile we have to get ready with the crash cart also.
Crash cart is ready.
Okay, and then now we will charge the paddles and then give the
What are the minimum requirements you want in crash cart?
the intubation things should be ready with an ambu bag, and the ET tube should be ready. All the emergency drugs should be ready, including the atropine, adrenaline, everything should be ready.
Okay.
Then the suction things should be ready. These things should be.
Then go ahead.
So now we will be charging the paddles and placing the paddles. In anterior position, we will be keeping just below the clavicle, right to the sternum, and the lateral paddle will be placed just below the left nipple, medial to the mid-axillary line. So we will be placing the paddles after applying the gel, and then we will be applying the shock, and then we will have to, after clearing everybody, will be applying the shock, and then we have to keep the paddles for 10 seconds.
Okay. The shock is delivered. We'll wait. So the heart rate has reduced now,
Yes.
but it is still irregular.
Yes.
Okay.
Yes.
So it's one part is corrected, but still BP is slightly low. What do you do?
Since the BP, since patient is having still an irregular rhythm, we can now go ahead with the rhythm controlling agents.
Okay.
So usually we give amiodarone injection. Amiodarone can be started for the patient, and the initial doses we'll give 150 mg over 10 minutes. And amiodarone comes, a vial of amiodarone comes 3 ml will be there, which is equivalent to 15 mg. So we'll be giving 150 mg. That is, we'll be giving 30 ml over 10 minutes, and following that we can give 1 mg per minute dosage for the next 6 hours. That will be 30 ml per hour dosage, and following that we can give 0.5 mg per minute, and that will be 15 ml per hour. That will be continued up to 18 hours.
Okay.
So we can start the patient on amiodarone.
So
Initial bolus can be given.
We can now discuss the case, but there is a basic mistake done during the process. What was the basic mistake done? There is a basic fundamental mistake done. What is the mistake?
For cardioversion sedation.
What is the mistake? You know that patient is in pulmonary edema. You know that patient is having coronary artery disease. You have not done something which is vital for the patient. What is that?
I didn't
Propped up
prop that.
position is not done properly. Patient is still lying down. That's a basic mistake that has to be corrected. Rest of the things are okay. There is no issue. Okay. Now, how do you manage atrial fibrillation? So this is a case of, according to Acls, it's a narrow complex irregular tachycardia. How do you manage that?
Initially, when a patient comes with irregular narrow QRS complex tachycardia, we have to see whether the patient is unstable or stable. So we look for 5 points. So if the patient is having any hypotension, if there is any features of shock, if the patient's having altered sensorium, if there is features of cardiac failure, or if there is any chest discomfort, then we consider the patient to be in unstable AF. If the patient is having stable AF, usually we can go ahead with rate limiting drugs or rhythm controlling drugs. So in emergency we prefer rate controlling drugs, and usually we give beta blockers or calcium channel blockers. We go ahead with beta blockers after ruling out any history of bronchial asthma or COPD. If they are ruled out, then we can give beta blockers.
What beta blocker you want to give?
You can go ahead with metoprolol. So initially metoprolol dose will be 2.5 to 5 mg can be given over 2 minutes, and you can reassess the patient after 5 minutes. So if the rate is not getting controlled, you can give a second dose. Like that, 3 doses can be given. Maximum of up to 15 mg dosage can be given. If beta blocker is contraindicated, then you can go ahead with calcium channel blockers. You have verapamil or the diltiazem. So in verapamil, you usually give the dosage of 5 mg over 2 minutes, and then you can, if the rate is not getting controlled, you can also start the patient on infusion with 5 mg per hour infusion can be started. In case of diltiazem, you can give 0.25 mg per kg initial dose. After 30 minutes, you can reassess, and if again rate is not getting controlled, you can give another dose of 0.35 mg per kg, and then start on infusion of 10 mg per hour infusion can be started. So these are the major
Here you have started amiodarone instead of beta blocker or calcium channel blocker. What is your intention by starting amiodarone?
Because already by giving a synchronized cardioversion, the rate had come down, settled. So next our goal was to control the rhythm, and rhythm control is done by the amiodarone.
Is there any other problem in this patient?
Patient was having hypotension also along with that. So it was an unstable AF.
Unstable AF, and you don't know the echo status.
Yes.
If echo status shows that ejection fraction is very low, maybe 40%, 30%, which is ideal to
Then if there is a cardiac failure associated with the AF, then we can also give digoxin. Digoxin 0.25 mg can be given for the patient.
Okay. So digoxin is one drug which can be started, but immediately it will not act. Whereas amiodarone act immediately. Its hypotensive actions are comparing to beta blocker or this one, it is
It's
low.
less.
That's why it has got a edge over other two drugs. Like you told, digoxin can be used for this patient for a long-term management, not for acute management. So digoxin also can be started. So echo shows severe reduction in the ejection fraction, atrial fibrillation. What else should be started for this patient?
If the patient is in our ICU, then we will also have to start on the anticoagulation also
What
should
will
be
you start?
started. So initially we can start with heparin and warfarin, because warfarin will take a minimum days of 5 days to get its action. So that bridging period can be given. You can also give heparin for the patient, and then you can continue the anticoagulation.
So heparin, what is the dose?
Usually we give 5,000 international units of heparin can be given for the patient.
5,000 of single dose.
Single dosage can be given for the patient.
Okay.
And then warfarin also, but while giving warfarin, we have to make sure the drug interaction, other drugs what the patient is taking also has to be considered, and also we will have to check the INR status of the patient giving warfarin.
So what should be the INR in a patient who is having atrial fibrillation alone, not a valve replacement or something?
Usually it should be between 2 to 3. INR value should be 2 to 3.
When you are starting heparin,
Heparin, you have to look, APTT also should be monitored for the
when you are
patient.
starting heparin, it should be APTT should be monitored. When you are starting warfarin, INR should be managed. Okay. How long we have to continue this warfarin?
Warfarin should be given lifelong for the patient.
What are the alternatives for this?
Newer anticoagulants also can be given for the patient, like rivaroxaban, apixaban can be given for the patient. If you are giving apixaban, then you can give 5 mg OD dose can be given. In case of rivaroxaban, you can give 20 mg can be given
His
for the
creatinine
patient.
is very high, 5. Can we give low molecular weight heparin for this patient?
No.
Yes, sir.
No.
Creatinine is 5. These are the practical problems we are going to face. Creatinine is 5. Can we give low molecular weight heparin? It has got an advantage that there is no need to monitor the APTT. Can we give that?
No.
Yes or no? Sir. So the problem is when the creatinine is high, there is a chance of increase in the action of the low molecular weight heparin. So better to go for conventional heparin, that is more than sufficient. Other one can be started, but it can sometimes create problem for you. Okay. So better to stick on to the heparin. Okay. So how you are going to discharge this patient? This patient is settled now, but there is another problem we have not discussed. We have not managed properly. What is the other problem? Like atrial fibrillation is there, everything is there. He has got pulmonary edema. How do you manage that?
In case of pulmonary edema,
We have not treated that at all. You didn't give the patient in propped up position. You didn't give Lasix. You only started BiPAP.
So in the after managing of the atrial fibrillation, we'll reassess the patient, and since the patient is in pulmonary edema, we'll have to give keep the patient on NIV, and then also also can give diuretics, that is injection Lasix can be given. A bolus dose of 40 mg can be given, and then following that you can keep the patient on infusion. Lasix at 0.6 to 1 ml per hour dosage can be given for the patient. And then meanwhile we have also taken the X-ray. We have also to check the X-ray for the pulmonary edema features.
So should we try bolus or infusion in this patient?
In this patient, we prefer infusion because bolus doses can cause hypertension in the patient. So we'll, instead of bolus dose, we'll keep on continuous infusion.
We start AC inhibitor for this patient.
Remodeling.
This patient had coronary artery disease. This patient has dilated ventricle. This patient has got low ejection fraction. This will be one drug which can prevent remodeling of ventricle. So that can be initiated. There is no other contraindication. But I told one problem that you didn't. Creatinine is high. So we cannot give AC inhibitors since the patient's creatinine is very high. Otherwise, you could have started AC inhibitor. What is the alternative for that? Which all other drugs will prevent ventricular remodeling?
Yes. ARBs also.
ARB also cannot be given because it's creatinine is high. Calcium channel blockers. Calcium channel blockers are good alternative for this one. Can we give calcium channel blocker here?
Yes. Hypotension is the only
there is a problem
contraindication.
here again. There is a problem. Calcium channel blocker cannot be given in this patient because his ejection fraction is low. His ventricle is in failure mode, so we cannot give a calcium channel blocker also. So what else you can add? So there is a problem here. This patient is having ventricular failure. There is a third drug which can also increase the prevent the ventricular dilatation. Beta blocker can. So low dose beta blocker can be started. You can build up the dose. Then spironolactone can be added. That also helps to prevent the ventricular dilatation. Okay, so all these things can be tried. Should we give aspirin, clopidogrel, statins, all these things?
Already patient is a known case of CAD.
You can continue that. But you are telling you are starting warfarin. Can we continue all these things along with warfarin? So
yes,
there are practical issues. You have to continue. So the action of these antiplatelet drugs are entirely different from warfarin. Warfarin is started for what?
Anticoagulation.
Where is it going to act in this patient? Where is the problem? Clot forms
in the
atrium. So it prevents the atrial mural thrombus, whereas other one, aspirin, clopidogrel, it is going to prevent the
antiplatelet action.
It's going to vessel. It is going to act in the vessels. Okay. Anything else you want to tell? Can we discharge the patient? Is okay? All right?
No.
Huh? Can we discharge?
No.
You should send him to?
For more cardiological evaluation should be done. Cause of AF should be ruled out. Samples, you should send all the blood samples, CBC, and look for any electrolyte
imbalance. What are other
imbalance.
causes for atrial fibrillation?
Atrial fibrillation, mainly there are cardiac causes and non-cardiac causes. In cardiac causes, any ischemic heart disease, any valvular heart disease.
So everything is there. He has got everything. But why he has come with atrial fibrillation now? He never had atrial fibrillation. One is ischemic heart disease that you know.
Then hypertension. Patient is also a non-case of hypertension.
Okay, that can trigger
this.
He's an alcoholic.
Other causes other than the cardiac causes are any hyperthyroidism, thyrotoxicosis can precipitate, alcohol can precipitate, then pulmonary thromboembolism can precipitate in the patient.
The most important reasons, one is checked for alcohol history, other one is thyroid history should be checked. Rest all things he is already having. There is a chance for all
Then
these
any electrolyte imbalances should be checked. Hypokalemia or hypomagnesemia also can trigger AF. So that also should be looked
very common.
into. Okay. So other causes also should be looked into, and so patient cannot be discharged immediately. What is the cause of AF also has to be looked into.
Okay. Keep the patient in proper position. Okay. So that you should never forget. Okay. Thank you.
Thank you.